Well, thanks. We're going to start. I'm going to close the door. Thank you so much for coming, everybody. It's my pleasure to introduce Dr. Gagan Singh, who is visiting us today from UC Davis. As many of you know, I worked at UC Davis for a long time, and had the pleasure of preceding Dr. Singh in training, and then eventually becoming colleagues together there. And he was always one of the rock stars of our cath lab at UC Davis. And as a fellow, people are already treating him like an attending. And then once he became an attending, we were like, oh, it feels like you've been here forever. And then, of course, Dr. Laird and I abandoned him and came here to this wonderful facility where he now graces us with his knowledge and presence. And he's here today to talk about the tricuspid valve, which is on the right side of the heart. And he calls it the forgotten valve. And I just like to call the right side of the heart the forgotten side. It's almost like, we all have hemi-neglect of the heart, and we don't have, we forget the right side is there, and we're like, well, what's the LVEF? And they're like, oh, it's 60, and everyone walks away happy. And I'm like, but the right ventricle is as big as my head, and people forget to talk about that. And so I think it's an appropriately titled talk. Gagan, of course, comes from an excellent pedigree where he did medical school at Stanford and came to UC Davis where he did training in the best cardiovascular fellowship program in the country, and followed with 2 years of interventional training, 1 year under the tutelage of Dr. Laird doing peripheral vascular training. But after he did that, he focused on structural heart really, and he's really been a driving force behind a lot of the structural heart work in the mitral valve area as well, and now they're venturing into, again, the forgotten side of the heart. So I'm so glad he's here. Thank you so much for coming, and Abbott is sponsoring the event, so help me welcome Dr. Singh.
Thank you, Kathy. It really is an honor and a privilege to be here. And so John asked me a couple of months ago if I would come up, and I told him sure I'd come up only for a bottle of wine, and of course he bailed on me, and he's not even here today. And but it really is a privilege to be here. I have a couple of disclosures. The first disclosure is that I am afebrile, and I don't have chills coming from Sacramento, California. I am COVID-19 free, and so these are some of my formal disclosures. And kind of the way I structured the talk is we're going to talk very little about history behind coronary interventions, structural interventions. I think it's a little bit important to kind of talk about where we've come from. As Kathy mentioned, that I am heavily involved in a lot of structural heart interventions, and not only just what we're currently doing, but where we're going. So I'll talk about the relative complexity of structural heart disease, and then kind of dive into the tricuspid valve. Surgeons for a long time have known the highly variable and complex anatomy of the tricuspid valve. And outside of 5 years ago, most cardiologists just knew that it was a valve, it was on the right side, and that was about it. But now that we're kind of venturing into tricuspid valve imaging interventions from a structural heart standpoint, we're starting to appreciate the complexity of the valve, and I want to talk a little bit about that. We'll talk a little bit about what the surgeons have been doing for the tricuspid valve for a long time, and what the recommendations are, and whether we can kind of try to mimic those with catheter-based options, and does it have an impact, and what type of patients does it benefit the most. And then we'll talk a little bit about currently what's kind of the leader for tricuspid valve interventions, the edge-to-edge repair technology, which is mimicked based on a lot of the stuff that was done on the mitral side. And then finally, I'll kind of close with some case examples, and also there's a clinical trial that's currently underway for tricuspid interventions for patients who need it. So, and then I hope this is somewhat interactive, so if you have any questions, please ask me, throw something at me. I'd be more than happy to pause and kind of help answer any questions. So, for the interventionalists or anybody involved in a cath lab, it's always fun to kind of go back and see where things started. If you look at coronary interventions or catheterizations, they kind of really started in the 20s. The Werner Frossman was actually ultimately became a urologist, but he was actually kind of did some catheterizations. He took a catheter through the vein, kind of advanced it all the way into his heart, and that was kind of the birth of catheterization, where he was able to measure the pressure in an intracardiac chamber. Mason Sones, who was out of Cleveland Clinic, was an interesting guy. He was actually interested in bringing catheters into the aorta and measuring pressures and giving contrast, and there was kind of serendipitous. The catheter happened to navigate into one of the coronaries as he was injecting contrast, and then when he was looking at it, he saw the coronary tree, and that was kind of the birth of coronary angiography. And even today, if you go to Cleveland Clinic, the cath lab is named after him. It's the Mason Soanes Cardiac Cath Lab. And then, this is kind of the earlier images from the work that he did in developing coronary angiography. This is the right coronary artery, and this is what the old X-ray tube looked like. So what we now have in the cath labs today is nothing nothing compared to what it used to be. And then obviously the birth of coronary interventions was Dr. Gruntzig, who looked at taking catheters and wires into the heart and doing balloon angioplasty. And of course, you can't be working in St. Helena and not know these kind of Dr. Palmaz and Dr. Schatz. So Palmaz of Palmaz Winery fame is really one of the inventors of the stent. And actually, people, I think John told me that Julio told him that, the way you make a small fortune in the wine business is to start off with a much larger fortune. And so, and people always say, his stent, the royalties that he still continues to receive from the stents is really what supplements his or subsidizes his wine enthusiasm. But anyway, so these guys actually, were sitting in a room and one day decided, hey, listen, we have all these problems with just balloon angioplasty. Why don't we just try to scaffold the artery? And that was so-called the birth of the stent. But so that's the coronary side of things. What about structural interventions? And actually we've been doing a form of structural interventions for quite some time. Pediatric cardiologists, adult congenital cardiologists. I've been doing atrial septal defect closure for a while in patients. And of course, we all know TAVR. TAVR is no longer a procedure; it's a career. And really, there's some sites out there that are doing 400 or 500 TAVRs a year, and it just takes a dedicated group of people just to focus on TAVR. But we had first high-risk TAVR FDA approval in 2011. I think the MitraClip is present at this site, and hopefully you guys are all aware of the MitraClip therapy that's available for a lot of patients for primary MR, and I'm not going to go too much into mitral regurgitation because that in itself is an hour-long talk. But MitraClip for primary mitral regurgitation was approved in 2013. And then, of course, there's left atrial appendage closure, MitraClip for secondary MR. Within here, there was approval for TAVR for intermediate risk, not just high risk, and now we have TAVR approval for low-risk patients. So we've come a really long way from kind of what we initially considered structural heart interventions to what we are able to do now. So, we spent a lot of time working on the aortic valve. We spent a fair bit of time working on the mitral valve, and so now, as Kathy pointed out, now it's kind of time to hit that forgotten valve, and is there something that we can do for patients who have a disease on this side, who are symptomatic, and can we impact their lives in a meaningful way? And why has it taken so long to get here? Why didn't we just do everything concurrently? Because I think if you look at the way the levels of complexity today, this is what PCI is. Okay, just driving down a nice road and just not turning. It's not like the Silverado Trail, but it's kind of taking a nice straight road, no major turns, no major branch points. But now in the current era, if you look at transcatheter aortic valve replacement, it's a little bit complicated, but we've streamlined it. You can't do 400 cases a year if it's an ultra complex procedure. But TAVR has become very streamlined, highly efficient, and we've gotten really good at it. And it's a little bit more complex than a straightforward PCI, but still, it is a very nice, elegant procedure. Then you start adding mitral interventions, okay? Once you start adding mitral interventions, it gets a little bit more complicated, right? Mitral anatomy is highly variable. Okay, in addition to that, there's gradients, there's afterload, preload, there's all these other variables that go into play when you start thinking about how to treat mitral valves. In fact, if you have a surgeon who does mitral surgery, you ask 5 surgeons how they would fix this valve, you'll get 10 answers. So, because there's a lot of different ways of doing it, and so it's very complex, and it's not as systematic as it can be, and there's a little bit of an art to it. And of course, then you add tricuspid valve interventions, right? And it's even more complicated, and we're learning that. I think others have known about it for a while, but for those of us who are involved in structural heart disease and structural heart interventions, we're just starting to get a flavor of truly how complex it really is. So this is an ultra simplistic view of the tricuspid valve anatomy. This is a kind of a surgeon's type view where the right atrial free wall has been opened up. You see the SVC coming in to the right atrium, the IVC is coming in, they're cannulated, and then these are retractors that have pulled the walls apart, and you're kind of staring down right at the tricuspid valve. The tricuspid valve in its most basic form has 3 leaflets, right? So these 3 leaflets, there's the anterior leaflet, there's a septal leaflet, and then there's a posterior leaflet. Now, I can tell you, having been involved in tricuspid valve therapies now for several years, this picture just doesn't do it justice. There is sometimes septations. It can be a quadrileaflet. It can have multiple papillary muscles, a subvalvular structure, the chordal structure, which are these basically parachute strings that attach to papillary muscles. This is highly complicated as well. So really, it's just a variability to a logarithmic scale higher than the mitral valve. And so which makes trying to develop catheter-based therapies for this valve really, really tough. But still, we're working on that. Now, that's the basic anatomy of the tricuspid valve. Well, the main problem with the tricuspid valve, if it does cause a problem to patients, is that it leaks, right? And similar to the mitral valve, there's 2 broad mechanisms for the tricuspid valve to leak, what we call primary or secondary. Primary is basically there's some sort of primary pathology with one of the components of the tricuspid valve. The leaflets are thickened or diseased. There's problems with the annulus. There's problem with the subvalvular structure. But it's only found in about 25% of the patients. You can have rheumatic disease, congenital abnormalities, some sort of pacemaker or defibrillator lead that's kind of tenting the leaflets opened. And those are really kind of going to be the minority of the mechanisms for why the tricuspid valve becomes incompetent and begins to have regurgitation. The most common thing that you'll see is actually, that we'll see as adult providers, is secondary causes. In other words, the basic anatomy is intact, but there is something else that is driving the tricuspid valve to become incompetent. The vast majority of the times, what we'll see is patients with left-sided disease. Like Kathy was mentioning, there's patients who have ejection fraction problems. There's patients who have diastolic heart failure, sleep apnea. There's patients who have mitral regurgitation. Those are all patients that the tricuspid valve is leaking because there's a backup of pressure from a pathology on the left side of the heart. Pulmonary hypertension is another very frequent cause of tricuspid regurgitation, all that backup of pressure. And something that we're starting to see more and more of is patients that have been sitting in atrial fibrillation, right? Not just in and out of atrial fibrillation, but just in chronic, permanent atrial fibrillation for a decade and a half, 2 decades. They come in with this isolated tricuspid regurgitation. I'll show a little diagram of that here in a little bit. And then finally, the wastebasket category of idiopathic tricuspid regurgitation. But in reality, what we're seeing now, at least for referrals for catheter-based interventions, are patients who have had left-sided disease or have undergone bypass or have undergone mitral or aortic valve surgery, but now several years later have developed tricuspid regurgitation. Or we're seeing these patients with permanent or chronic atrial fibrillation. The decision was made to leave them in atrial fibrillation, or it was very difficult to maintain normal sinus rhythm. Those are the main patients that we see who are coming in with tricuspid regurgitation now. So even though the valve and the anatomy is very complicated, even the way it develops tricuspid regurgitation is very complex. So again, here's kind of that surgical view of a normal tricuspid valve. There's the anterior septal, posterior leaflet. Again, I actually don't think that the septal leaflet is this long. It's a little bit of a misrepresentation, but it's a very 3-dimensional structure. But if you were to slice it like this and turn it on its side, you would see that it's more saddle-shaped. This is the lowest part of the tricuspid valve, and this is kind of closer to where the annulus is. When it does get diseased and the right ventricle enlarges, it enlarges asymmetrically. This is where the RV free wall is, and so it kind of dilates out that way. And then what happens is that the annulus actually flattens out, where it goes from a saddle and actually comes down and totally flattens out. So when a surgeon does some sort of procedure here to reduce it, they don't basically put in some sort of circular structure. They actually put in a ring, and it's actually a partial ring. And the partial ring, the vast majority of the time, and there are some other surgical techniques that can be done, but really the annuloplasty ring is really the main method to help bring this free wall back in and bring that annulus back in to help increase coaptation and thereby decrease regurgitation. So that has been a highly effective treatment for these patients who develop secondary tricuspid regurgitation. Now, another diagram kind of highlighting all of these points is that on the left, what you'll see is here's the mitral valve, there's the aortic valve. As pressure or some sort of disease backs up into the lungs, which then gets translated down here, and what you'll see is there'll be RV enlargement, and if there's RV enlargement, you'll get loss of coaptation. But then here's another mechanism of tricuspid regurgitation where it's just patients with chronic atrial fibrillation. The left ventricle may be okay, the mitral valve is okay, the aortic valve is okay, there's not a lot of pulmonary hypertension, but you get this chronic atrial fibrillation, and you get massive right atrial dilatation, and what happens is the tricuspid valve, just the annulus gets pulled apart, and you get loss of coaptation. And as you get loss of coaptation, you get a fair bit of regurgitation as a result of that. So that's one mechanism of just pure isolated tricuspid annular dilatation. And then these are patients with pulmonary hypertension. I don't know if you can make it out that well, but if you look at the orientation of the papillary muscles here, these are the muscles that hold this chordal structure attached to the leaflets. You know, again, I think the way I describe it is kind of like a parachute. And I don't know if you can make it out, but these papillary muscles are aligned like this. But in patients who have pulmonary hypertension, the RV enlarges, the right ventricle enlarges. What you see is these papillary muscles are now oriented like this. So you get these papillary muscle displacement, and then the leaflets get pulled down and out. And when they get pulled down and out, they're called restricted, and now as a result of that, they get regurgitation from there. So really, there's a very wide, diverse group of etiologies for the tricuspid valve and what leads to tricuspid regurgitation. We've known that for a while now, but in terms of how to image it, how to attack it from a non-surgical standpoint now, or if patients have already had surgery, you know, it's kind of something we're working on. When patients dilate their right ventricle this way, when their patients develop severe TR, coming in and doing a tricuspid valve replacement is actually, you know, technically may not be that difficult. Doing an annuloplasty ring in and of itself may not be that difficult. The hardest part usually is when their right ventricles are this bad and they come off of pump and try to keep them off pump. That's usually the hardest part. The critical care management of these patients post-operatively tends to be the most difficult part for these patients. These are some very, very, very sick ventricles. So say we've understood exactly where tricuspid valve comes from. We've understood, you know, where the pathology comes from. We have all this rich history with aortic valve disease and mitral valve disease. Well, how do you image the tricuspid valve? And you know, this is also something that there's a lot of interest and excitement over. I don't know if there's anybody interested in imaging in the room. You know, before you just put your echo probe on the tricuspid valve, you assess how much regurgitation, and you call it a day, right? But it actually is, it's getting more and more complex. The quantification of even TR, of tricuspid regurgitation, has just developed a whole new field in cardiac imaging. So this is basically a table that summarizes the number of pages dedicated to the tricuspid valve in the societal guidelines. So the American Society of Echocardiography, right, that's the main kind of governing body over people who are into imaging. And if you look at back in 2003, mitral valve and aortic valve versus tricuspid valve and pulmonic valve, and really this is mostly tricuspid valve, right? There's a ratio of 2 to 1. There's a lot of emphasis on understanding mitral valve and aortic valve pathology. Fast forward to 2017, right, now there's like, you know, we kind of increased initially a lot on the mitral and aortic valve because that's where the emphasis was, and we kind of forgot about the tricuspid valve. But now look at this. Now we're kind of back to a 2 to 1 ratio. All right, I feel like this is like a Top Gun thing, you know, the kill ratio in Vietnam was really bad, and then we got better at it. So it's kind of similar to that scenario. There's more and more interest now in the tricuspid valve, and actually we're learning quite a bit. And it's actually not just echo. You're going to start seeing this more and more, especially for patients with structural heart disease, not just so much for the aortic valve and mitral valve, but for the tricuspid valve too, is that there's going to be a lot more emphasis on the use of CT and cardiac MR, and to quantify the regurgitation, the effect that it has on the supporting structures, predominantly the right ventricle when you talk about the tricuspid valve. And then you're also going to talk about tricuspid annular dilatations, and it'll allow you to assess a lot more when you're able to do it completely with CT and cardiac MR, and echo will be there as well. But really a Venn diagram of multiple imaging modalities, and all of them help to answer different questions and give you a much better understanding of what the pathology is and where patients will benefit the most. So, you know, why are we even talking about the tricuspid valve and tricuspid regurgitation? You know, for 40 plus years, we know, you know, Kathy was one of my attendings when I was growing up, and she would always, you know, teach us about medical therapy for mitral valve disease, or she would teach us about medical therapy for left ventricular dysfunction. There really is no proven, you know, high-level data, mortality-saving data, medical therapy for patients with tricuspid regurgitation. If you go to the guidelines predominantly say, hey, listen, just treat their left-sided disease, and then the tricuspid valve will get better. We don't really have any sort of proven therapy. Surgery for the longest time, what the surgeons would do, if somebody came in, this is, I don't know if St. Helena is considered the meth capital of California. We get a fair bit of it down in Sacramento, but I think you get a fair bit here too, right? You get a lot of these patients with endocarditis, IV drug use, and for the longest time, surgeons would just take the whole tricuspid valve out. And the patients would just sit with torrential TR and actually tolerated it fairly well as long as they had preserved RV function. So, and then that's for primary TR, but for secondary TR, the thought was that if you fix the left-sided disease, and if you fix their mitral valve disease, if you fix their aortic valve disease, if you got their blood pressure under control, the significant TR, the tricuspid valve, was not that big of a deal. Turns out that's not true. Okay, so this is a kind of a meta-analysis. So they took a bunch of different clinical trials and they pulled all the data together. And what they did was they looked to see if a surgeon was taking a patient to the operating room and that patient had severe TR, in addition to whatever, mitral valve pathology, aortic valve pathology, and say if the only thing that happened was that they treated the mitral valve disease or they treated the aortic valve disease, they got aortic valve replacement, mitral valve repair or replacement, but if you left the tricuspid valve alone, or if you treated the tricuspid valve, collectively it would suggest that if patients who got a tricuspid valve annuloplasty in addition to their left-sided disease, they actually did a lot better. Okay, so whether you looked at all-cause death or cardiac-related death, again, it seems like if you can treat the tricuspid valve at the time of their left-sided surgery, this is beneficial to them. Tricuspid regurgitation is bad. In patients with or without left-sided disease, patients with or without pulmonary hypertension, the more TR you have, the more it is intimately associated with long-term mortality. This is a Palo Alto VA study of about 5,000 plus patients, and they looked at everybody. Again, whether you had pulmonary hypertension or whether you didn't have pulmonary hypertension. If your ejection fraction is low or your ejection fraction was positive. These are called Kaplan-Meier curves and survival curves. So they started off at time point 0 and go all the way out to 1,500 days, right? So several years, 5 to 6 years out later. This is kind of the 100, everybody's alive. If you kind of stay on this line all the way at the top, you're alive. If you go all the way down to 0, that means you're dead. Right? So if you look at here, if you have, and there's a clear difference in gradation. So whether you have mild, moderate, or severe TR, right? If you keep going out up to 5 years, it is associated with mortality. Moderate to severe TR is bad. Okay, so the TR in and of itself may be a symptom of the bad RV, but irrespective of that, it's an early indicator that something is wrong and needs to be addressed. Okay, again, whether you have pulmonary hypertension or not, because one of the discussion points at a lot of our meetings always is, well, listen, TR is a symptom. That's not the primary problem. It's not the disease. I already told you a lot of TR is secondary, but again, whether you have pulmonary hypertension or you don't have pulmonary hypertension, presence of moderate to severe TR is associated with mortality. Here's a little bit of a complicated graph here, but I'll kind of walk you through it. Here's again, patients that underwent some sort of surgery, right? Actually in this particular case, it was mitral valve repair or replacement. So patient underwent a mitral valve repair or replacement, and they did not undergo tricuspid valve annuloplasty at the same time. So that's time point 0. And then they followed these patients. And the patients who they followed who developed moderate or they developed severe TR over time, they actually did worse, okay? And so they were dying off a lot more. And what were some of the risk factors associated with patients dying off a lot later? If they were of older age, more importantly, and this was the highest predictor, if their tricuspid valve annulus was dilated. Okay, this was the most strongest predictor. If your tricuspid valve annulus was dilated, that was actually going to be associated with more TR, hence more mortality down the line. So there was a very high prevalence of late tricuspid regurgitation if you left the tricuspid valve alone at the time of mitral valve surgery. TR is bad. Tricuspid regurgitation is bad. Patients die off from it. So a couple of years ago, this was from the Journal of American College of Cardiology, and this is the current surgical approach to patients who have surgery for some sort of left-sided disease, aortic valve surgery, mitral valve surgery, and you look at the right side of the heart. If the right side of the heart shows moderate to severe TR on the intra-op echocardiography, then they're supposed to undergo a tricuspid annuloplasty. If they don't, that's great, but then it's important to assess the annular dilatation at that time. If the annulus at that time shows that the annulus is dilated, right, or there's a significant mismatch, then they're actually supposed to undergo annuloplasty as well. Again, to prevent that late recurrent TR. And if you don't have a lot of TR, you don't have annular dilatation, you kind of leave the tricuspid valve alone. This is, in addition to isolated long chronic AFib, this is probably the second most common reason why I see referrals for patients with with TR currently, is because at the time of whatever their surgery was 5 years ago, 6 years ago, 3 years ago, they didn't undergo a tricuspid annuloplasty at that time. So what about patients undergoing transcatheter therapies, right? I'm actually not a surgeon, I'm an interventional cardiologist, and we do a lot of transcatheter aortic valve replacements and mitral valve replacements, or mitral valve replacements and repair at our institution. And what we're seeing now and more is this is again a meta-analysis of a bunch of patients undergoing MitraClip or the undergoing transcatheter aortic valve replacement. And actually, if you had tricuspid regurgitation at the time of these procedures, you had relative increased mortality. So we're understanding more and more from a surgical side that if you have a disease, you need the tricuspid valve all at the same time. But now we're taking older patients, sicker patients, for left-sided treatment with a catheter, and we're leaving their tricuspid valve alone. The same thing that we're learning from the surgical literature is something that we haven't necessarily been applying, but now we're starting to understand that, and we clearly appreciate that, you know, even in patients that are undergoing structural heart interventions, residual TR is bad and probably needs to be addressed to help improve symptoms and improve long-term mortality. So how do you get there? What are some of the available options from a transcatheter standpoint, right? Because like I said, you know, isolated tricuspid valve surgery is exceedingly rare. And generally patients don't seem to do well with the hit of going for surgery for just isolated tricuspid valve. Younger patient, maybe. A lot of these 70, 80, 90-year-olds, certainly not. So what are some options for percutaneous tricuspid valve repair? This is from a book chapter that I wrote for an interventional cardiology textbook. And it kind of highlights all the different transcatheter options that are currently in various stages of development. This is a $3+ billion industry right now. A lot of it is just money being pumped into developing new technologies. What a surgeon does predominantly, the most effective therapy for patients with secondary tricuspid regurgitation is an annuloplasty system. So to mimic that, there are multiple catheter-based devices that are in various stages of development. None of them are currently FDA approved or have CE mark that kind of try to mimic that. This is a tri-align procedure. There's a Cardioband which tries to mimic annuloplasty, the partial annuloplasty, which seems to be the most effective in the tricuspid position. There's ForTec as well, which tries to mimic the bicuspidalization procedure that a surgeon will do sometimes. Millipede is a complete annuloplasty ring that's implanted. Again, very, very, very experimental at this stage. And then there's some weird technologies that go outside of the heart. You actually puncture into the pericardial space and you anchor it and you bring the tricuspid annulus in. I don't think those are going to be long lasting, but it never makes sense to actually puncture outside of the heart. We've tried to avoid doing that for 30 years, and now people are telling us to do that, and I don't think that sounds right. I'll talk a little bit about Forma device. It's kind of an interesting concept. I also don't think this will be the mainstay. Obviously, I'm going to talk a little bit about edge-to-edge repair technologies. This is kind of an interesting field. We know that patients who have severe tricuspid regurgitation, they don't feel well because all that regurgitant volume goes down the IVC, so they feel bloated, they have swelling in the legs. They put all that swelling or all that regurgitant volume goes up their SVC as well. And so what some folks have done is they've actually taken the TAVR valve, flipped it upside down, and put it into the SVC IVC. So thereby you prevent all that regurgitant volume transmitting into those vascular beds. You haven't fixed the underlying problem, but you've actually just prevented the symptoms. Again, this doesn't seem to work. It's not that durable. Patients don't like this for too long. Initially, they may feel better, but then the right ventricle gets even more and more stressed, and this doesn't seem to be a durable therapy for them. And then finally, if there's difficulty with surgical annuloplasty, one of the treatment options is just surgical valve replacement. You can actually wring down the entire tricuspid annulus a lot better sometimes with a tricuspid valve replacement. And so could we kind of do that from a transcatheter standpoint as well? Could we actually bring a device in and go ahead and put it in the tricuspid position? Turns out that it's not as simple as TAVR. TAVR is a discrete, nice round structure, and you have a round peg and you're putting that into a round hole. Both the mitral and even more so the tricuspid annulus are not round. They're very oblong, they're very heterogeneous with a very complicated subvalvular structure, and so it makes it even more difficult to just go in and put to go ahead and put a device in there, a full device. So the Forma device, which is the spacer technology, probably has some early experience behind it, and I'll kind of talk about that a little bit. So what the Forma device is basically if you look at the tricuspid valve, here's the SVC as you come all the way out to the kind of similar location where a electrophysiologist might get access to put a pacemaker in. Kind of in that similar manner, what you do is you kind of access the subclavian or the axillary vein, you get percutaneous access, you advance your wire all the way down the SVC through the tricuspid valve, and then you place an anchor in the RV apex. Again, not too dissimilar from what an electrophysiologist may do. And then what you do is you advance the spacer. And the spacer is, there's many different sizes that come of it. And that spacer then basically takes up space. Remember, the tricuspid annulus dilates in a lot of these patients, and as the leaflets come together, they just don't touch each other. They don't coapt. And as a result of that, if you can put a spacer right down the middle, now basically that tricuspid valve is actually touching something, and you can actually prevent regurgitation around it. So it's a very simple solution to a very complicated problem. And actually they have some very early experience behind it. You know, again, the latest publication is just about 17 patients. This is what we call an early feasibility study. And in this very early study, right, in these follow-up patients, you know, out of those 17 patients, you know, 4 died, you know, 23%. These are sick patients. Cardiovascular and all-cause mortality is somewhere between 20 to 25%. If you look at the patients who did survive, though, they had improvement in their New York Heart Association class. So we all know the symptomatic benefit is kind of what we're striving for. Patients have a better quality of life based on these objective parameters that they used to assess. TR severity did reduce. A lot of these patients had severe TR, and they were left with mild to moderate TR in about 2/3 of the cases on 30-day follow-up, and also approximately about 1-year follow-up. The vena contracta is essentially a fancy term for how wide the tricuspid regurgitation jet is as it comes through the tricuspid valve. And the vena contracta, the larger the vena contracta, the more tricuspid regurgitation there is. The smaller the vena contracta, the less tricuspid regurgitation. And so again, at 30 days and out to about 1 year, it seems to be about maintained compared to where the patient started off with. So the biggest, I think, hurdle for the Forma device is going to be its complication rates. It's a much easier procedure to do, much easier device to get in there. Perhaps it may have a role in patients where the RV has gone way too big. This device is probably not going to save lives, but it may improve quality of life. And if it does come to the market, it's probably going to be based on a quality of life data set, because there are a lot of complications. Patients, because you can imagine you're kind of going into the RV apex, you're trying to put a stiff anchor in there, and the RV apex is a very thin-walled structure, unlike the left ventricle. So very easy to kind of have problems related to this device in its current iteration. So we'll find out more as the years come whether this is going to be a mainstay of therapy. So I'll talk a little bit about edge-to-edge repair now. This is kind of where my main kind of interest is from a clinical and a research standpoint. Edge-to-edge repair, as everybody in the room, hopefully, there's St. Helena here is a MitraClip center, and both John and Monica and Mark, I think, have been doing a lot of the MitraClip work here. And you can actually use that same MitraClip system to treat the tricuspid valve. For the longest time, what we did was you took the device and you kind of modified it the way you inserted it, and you could actually, even though the catheter is designed entirely to come up the IVC, across the interatrial septum, into the mitral valve, you can kind of modify the way you inserted it, and you can actually go ahead and bring it down to the tricuspid valve. You know, we were one of the earlier sites to try to do that, and I can't even begin to tell you how difficult that was. Because now you have a catheter that's specifically longer, specifically designed for the mitral valve. Now you're trying to get it into this place that's a very tight turn and a much smaller space to work from, where the leaflets are much more thinner, much more variable, and the imaging is even more complicated for the tricuspid valve. So we were kind of helped participate in some of the early off-label experience behind it, and I'll kind of share with you some of our experience based on that. Kind of, I think all of us who were involved in some of the early experiences went to the company and said, listen, you guys need to put this clip, the exact same clip that we use on the mitral side, you need to put it on a catheter and a delivery system that makes it a lot easier just to get to the tricuspid valve. Because we're doing a lot of stuff right now, it's 10 times harder, but if you can do that, that's really going to help us. And that's what the Triluminate trial is. That's the one that I'm one of the primary investigators for at UC Davis. And what I'll talk to you a little bit about today, I really think that this particular trial, and actually Jeff Perez is here from Abbott, and he actually was kind enough to bring the device. So you guys can all be tricuspid clip implanters if you would like, for this morning at least. But really, I think this particular therapy is really going to be helpful for a lot of patients with symptomatic tricuspid valve disease. And we'll talk a little bit about that. So Again, when we talk about off-label approach for the tricuspid valve, what we would essentially do is this. This is the MitraClip guide catheter as it comes in on X-ray. And what we did was we placed one clip in the mitral position. Again, we modified the delivery system, the way to deliver 2 clips to the tricuspid valve position. This was a very early experience with treating tricuspid valve disease with the clip-based system. And this is actually now currently in press. Paul Tsaraja is one of our leaders in this field. We kind of collectively, with a bunch of different sites, put all of our data together, everybody who was doing this off-label, and we looked at a lot of our data set, and we saw that, hey, listen, with this approach, it's not perfect, but if you looked at severity of tricuspid regurgitation, you could actually decrease that. These are all patients with severe tricuspid regurgitation at baseline, and then if you look at post-procedure and up to at least 6 months of follow-up, you saw patients had an improvement in their TR grades. Improvement wasn't what we're seeing with MitraClip in the mitral side, right? You go from severe to mild, and that's the goal now. Patients should not be leaving a MitraClip procedure with moderate MR anymore unless there's anatomic challenges, but we're striving to get everybody down in the mitral side to as low as possible. Tricuspid valve is kind of where we were with mitral 10 years ago. Even if you can get 1 clip on, you can reduce it with 1 grade, given our technical challenges, we were really happy. And that's kind of what we did with the earlier data set. We saw these patients, we took them from a severe to moderate, and you would never accept that in a mitral position, but in the tricuspid position, we were pretty happy with it. But look at this, patients actually did better. These are patients with class 3, class 4 heart failure symptoms, and there was a lot more patients just by cutting the TR grade by one. Patients actually did a little bit better, and they felt better. So we learned a lot from this initial kind of experience by using the MitraClip system in the tricuspid valve. What we learned, that procedural success definition, at least in this very early experience, is that even if you can reduce TR by 1 grade, it was difficult, but we only achieved it in about 2/3 of the patient. 1-year mortality is 20%. These are some very sick patients. So 1 in 5 patients who we treated with this, didn't do so well. It's not the procedure that killed them, is that they are just sicker patients. They have RV dysfunction, RV enlargement, and so we have to kind of keep that in mind when you kind of design a trial or try to develop a technology and you're trying to figure out who's going to benefit from it the most. In the patients who actually did survive, they had an improvement in their TR grade and they actually felt a lot better. We know that there are certain patients that and that's one of I think the most important things that we learned from this very early experience is who will not benefit. If you have a pacemaker and ICD lead, which a lot of patients do, it doesn't necessarily mean that if a pacemaker and ICD lead in there, it's going to be problematic, but if it's in there and if it's tethering one of the leaflets open, obviously this technology is not going to work. So that's one group of patients where this technology will not work. And what about the leaflet gap? I talked about that gap when the leaflets come together. If that gap is greater than 7, it's going to be a lot more difficult. In fact, if it's less than 7, that's fantastic. If it's above 7, it's probably not going to work. If it's above 11 or 12, it's definitely not going to work. So I'll talk to you in the Triluminate trial, I'll talk to you, we are allowing some patients above 7, up to maybe 10, up to 11, but beyond 11, 12, forget it. There's no therapy that's going to work for them. And those are probably the patients that are just too far gone, and they're not going to do well over the next year anyway. So finally, the company kind of made a dedicated tricuspid clip system. If you've ever seen the MitraClip system, it doesn't look too different. A few of the knobs are in different locations, and then the delivery catheters here at the end are shortened to help get directly from the IVC into the tricuspid valve. And then what you'll notice is that the clip actually otherwise is totally the same as what was used in the mitral position. So here's kind of the earlier, finally, we got the device, started putting it into patients in what we call the early feasibility study, or the EFS. The early feasibility study was just 21 sites, right? And it was kind of prospective single arm. We just put the device in, single arm, follow these patients. Because one of the things in the US, if you want a device approved, you need to demonstrate safety, and then you need to demonstrate that it's efficacious against what standard of care is. Otherwise, the FDA is not going to approve it, and Medicare is not going to reimburse it. So those are the important 2 things that need to be satisfied before you can bring a device to market here in the US. In Europe, it's a little bit different. The governing body that's analogous to the FDA is something called a CE mark. So you need a CE mark to be able to commercially kind of market devices. In Europe, all you got to do is demonstrate safety. You put it into 10 people, if 9 are still alive, the European governing bodies say, go ahead, go at it. So there's dissatisfied 2 requirements. One is the EFS study to try to get European approval, but more importantly, to first do the safety study, and then you can do the pivotal trial where you can randomize to what standard of care is, and if it's efficacious, then the FDA will approve it. So this was the therapy that we use for the tricuspid position. It's single center, prospective, and the goal is to put a clip on and reduce TR by at least 1 grade, 30 days, and then we're going to look to see if it's safe at 6 months. All right, and then you took patients that had moderate or greater tricuspid regurgitation, and more importantly, and this is probably the most important part, is that, and this will hold true for the pivotal trial too, is that they can't have any sort of left-sided disease. So if you have bad EF, on good medical therapy, and you have severe mitral regurgitation, that needs to be treated first, and that's what the COAPT clinical trial taught us. That needs to be treated first, whether it's with more medical therapy or with MitraClip or some sort of other catheter-based therapy or surgery. That needs to be treated first before you're going to consider any sort of tricuspid valve intervention. If you have aortic stenosis, that needs to be fixed first before you're going to go after tricuspid valve disease. And again, if you had other reasons to have tricuspid regurgitation, you were excluded. And then if you had a bad ventricle, you were excluded as a result of that. I usually don't like to put too many table slides, but I thought this was important because this is the patients we're seeing now for tricuspid valve disease. This is kind of what their demographics looks like. Right? These aren't 50, 60-year-olds. These are like kind of patients in their high 70s that are being referred for tricuspid valve interventions. They have a lot of problems with lower extremity edema, fatigue, hepatic congestion. 2/3 of them are women. A lot of patients have a history of hypertension, but look at this, 92% of these patients have atrial fibrillation. Atrial fibrillation is long-term, is terrible for patients. It's really, really terrible. This is what I'm seeing a lot in my practice. I'm a structural heart interventionist who specializes in valvular heart disease. If you leave patients in AFib for a decade, 15, 20 years, they come back with a lot of valvular heart problems. And so we're seeing this over and over again. Again, patients with any sort of prior surgery. You know, these are patients who underwent some sort of prior surgery who did not get tricuspid valve intervention at that time. We're seeing this quite frequently. And then again, patients with pacemakers relatively were excluded, or ICD leads were excluded, but as long as the pacemaker lead or the ICD is not impinging on the leaflet, they're okay. We can still try to attempt to clip them. And then we had some additional measures, hemodynamic measures, but really I just wanted to talk a little bit more about what the patient profile looked like. This was kind of the take-home message that we actually learned from the mitral trials, and it's the same thing with the tricuspid trials. This device or this therapy is an ultra-safe procedure. If you look at success rates of implantation, success rates of device being put in there, it's 100%. At no point, unlike TAVR, there's no hemodynamic shifts. There's no need to have perfusion in the room. There's no need to have all this personnel in the room. There's no rapid pacing. There's no major hemodynamic swings. Patients don't need A-lines. They don't need pressors. And procedural success, which is defined as implantation of 1 clip and reduction of MR grade by 1, was 92%. So again, a very high success rates. And again, this is again something we learned from the earlier clinical trials for mitral, whether it's Everest or COAPT. This is a very safe procedure. If you look at overall adverse event rates, right, relatively low compared to what we were expecting. This is a sick group of patients. Mortality rates were expected to be about 20%. And just if you look at overall adverse event rates, there were only about 2.7 or 3.7%, and that included mortality. And so it really is a relatively safe procedure from an overall standpoint. Now, there's some other things that we looked at out to 6 months. This is some of the 6-month data that you're seeing now. You know, major bleeding, and this is, again, vascular access complication, which is not any higher than kind of other clinical trials, atrial fibrillation. And this is one of, I think, I wouldn't say Achilles heel, but one of the limitations of this therapy is that your goal is to bring a clip in, attach to one leaflet, attach to another leaflet, and close the clip. So if you dislodge, or say if one of the leaflets slips out, most of us would just call that detachment, right? But if you're a giant company like Abbott, you don't want to use detachment. That has a negative connotation. Okay, so instead you call it SLDA, or single leaflet device attachment. So I'm still attached. Attached is a positive word. It's not a negative word. So, but basically is the clip has detached from one of the clips, but it's still attached and it's just swinging around. So at most what happens is patients are still left with the same amount of tricuspid regurgitation that they came in with. Same applies for the mitral position. We've never seen, you know, you go from severe to ultra severe. And then no embolization. And this is important too. You know, we always say that when I see patients in clinic, I always tell them the goal of the clip is to help reduce the leaking, but we also want to maintain the opening. Because if you don't maintain the opening, then all of a sudden you can't send blood in the normal direction. And so anything above 5 was considered significant, but clinically all these patients tolerated it pretty well. So where do we put the clips, or how many clips we used? The vast majority of patients got 2 clips. Some patients needed 3, and very rarely some patients needed 4. Location is important. And if this is the aortic valve, the RV free wall is around here. So again, most of the enlargement occurs this way, right? And so most of the clips were actually 77% of the time were placed between these two leaflets. And this is again something we're learning. Where do you put these leaflets? How do you put them in? What mechanism? What order? What size clips? And that's something that we continue to learn from. In terms of 6-month effectiveness in this now more rigorously conducted study with a dedicated device, what we see is that if you look at patients with TR grade, a lot of them had moderate to severe, and we were able to reduce their severity. Now, this is kind of interesting, right? You would think I'm joking here. We're using the word severe and then massive and torrential. And what's next, tsunami? I mean, but it really is. There's actually, it seems like even in severe tricuspid regurgitation, there seems to be a gradation that matters clinically. So there's a phenomenal cardiologist by the name of Becky Hahn. She's at Columbia University. She's really pioneered a lot of this imaging and quantification work, where she's taking the entire severe category and divided it up. And a lot of this is based on that vena contracta, that gap. But we know that there's some patients that have torrential or ultra-torrential, or what I call tsunami, that those patients are probably not going to benefit. But it's really, these are the patients. And even I am learning with every sort of transesophageal echo that we do for these patients, this is a much more important group to target now than this group. This group is probably too far gone for benefit from tricuspid valve therapy. And that's something that we're looking at right now. So, but at least from this 6-month initial experience, these patients, they have a reduction in TR grade. And this is kind of a little bit technical. If you're an imaging geek in the room, you might like this. If not, I'll kind of glaze through it. Basically, these are some quantitative measurements of the tricuspid annulus and the tricuspid valve, and they all improved at 30 days, and they all improved at 6 months. Patients felt better. There's only 25% of the patients were class 1 heart failure or class 2 heart failure, and then there was more class 1 and class 2, almost 80 to 87%, and it seems to be durable out to 6 months and maybe even getting better over time. If you looked at objective and non-objective scores, all of them improved over the 6-month period of quality of life indicators. This I thought was interesting, and this is something that we saw in the earlier mitral trials and even with COAPT, which was a trial that looked at mitral interventions for patients with functional mitral regurgitation. But we're seeing some positive remodeling benefits in the right side of the heart too, right? Dr. Tong mentioned earlier that the hemi-neglect, that you kind of forget about the right side. But if you clip these patients, there's some patients where actually the right ventricular, right atrial parameters actually improve, and that's a remodeling benefit that actually may be helpful long term. So I wanted to summarize at least the early feasibility data, which show that there's very high procedural success. There's safety is actually, I think pretty good for this really sick group of patients. We have objective data and subjective data that patients actually are getting better, and some of this is durable at least out to 6 months. And so this was kind of what led to us kind of working towards what we call the pivotal trial. All right, I'm going to kind of skip this, and this is kind of what I think we are actively enrolling for. This is the trial I think that is really going to help answer, hey, we know it's safe, but next the question is it going to be effective? Can we really help these patients from a quality of life standpoint? Can we really help these patients and make them live longer? And if not, which ones does it work in? Which ones should we not offer this therapy to? So this is actually a much larger trial. So when you do an early feasibility study, much smaller, but when you do a pivotal trial, you need much larger data set. So about 450 patients. This trial just got up and running last year. What we're going to do is we're going to compare this tricuspid clip device and look at patients' symptomatic tricuspid regurgitation, and we're going to see if it helps them. Now there's 2 arms to this therapy. So when I see a patient in clinic, what we'll do is ultimately they'll get a transesophageal echo. And when they get the transesophageal echo, unfortunately there's a lot of views that need to be done, specific for the trial and specific for TR, tricuspid regurgitation assessment. So this transesophageal echo has to be done at a site that does the procedure. So what we do is we take a look at the transesophageal echo and we look at the coaptation gap. So in other words, how far are the leaflets apart? Okay, and if the leaflets are less than 7, and that's kind of the general qualification criteria so far, is if it's less than 7, generally they fall into this arm, the randomized arm, okay? because that's a group of individuals. If it's less than 7, we really think that you can put a bunch of clips and not just decrease their TR by 1 grade, but bring them all the way down to mild. The goal is not just a little bit of reduction, we want to reduce it as much as possible. But then what about these high-risk patients? You know, what about these high-risk patients where the TR gap or the coaptation gap is greater than 7? Say if it's 9, 10, 11. So then they'll fall into the single arm, you know, which is, hey, listen, we're not going to randomize you. We're just going to go ahead and treat you and see if we can get a couple of clips on, and does it make a difference? And we'll follow these patients. What about the randomized arm? What do you get randomized to? And then you tell patients this, and they're like, oh, man. So you come in, say you get your coaptation gap is less than 7. What I would tell patients, basically a computer basically decides, 50-50 chance. You're either going to get randomized to the device, or you get randomized to just continuing the medications, continuing what you're doing right now. So that's the control arm. That's the medical therapy arm. So of course patients are going to be bummed that you got randomized to just medications. They went through all of that for nothing. However, one of the good things about this trial is at the end of 1 year. So if you've undergone a year, you can get the device at that time. So it is medical therapy, but it's just for 1 year, and after that you can treat them with the clip and see how they do. So who are the patients that we're looking for in this trial? Basically, these are patients that have been on good medical therapy. If you've not been on a diuretic, we want you on as much diuretic as you can tolerate. If you have uncontrolled blood pressure, that needs to be treated first. If you have symptomatic mitral regurgitation and you have a bad ventricle and you have ischemic or non-ischemic mitral regurgitation, that needs to be treated first. If you have aortic stenosis, that needs to be treated first. So basically all your left-sided disease has been addressed. You're on appropriate medical therapy, and if you still have symptomatic tricuspid regurgitation, those are the patients that are being considered. Now again, the transthoracic echo and the transesophageal echo, all of that has to be done at a site that does the procedure. Some important exclusion criteria: if you have pulmonary hypertension, right? If you have very high PA pressures, TR is not the problem. The problem is the PA pressures, and that needs to be addressed first. If you have uncontrolled blood pressure, a very low ventricle, and again, or some sort of anatomy that gets in the way of doing the procedure, then you can't do it. Because this is a mitral clip site, I would add that, you know, if there's been any sort of mitral intervention, we'd have to wait at least 60 days before we offer it to them. So this is kind of interesting. Like, say if a patient does come in, we see them, we review them, we ultimately treat them, and again, there's a timeline which I won't necessarily go into, but we'll treat them, and then after we treat them, then they go home. And this is something very unique to this trial, which I think you're going to start seeing more and more with trials coming down. One of the biggest disadvantages of living in this area in Northern California is that, you know, we have a huge referral network from all the way up to Oregon, to all the way east to Reno, down to Bakersfield. Patients come from really, really far. They want their treatment, then they want to go home. They don't want to keep coming back every 30 days, 6 months, 1 year for visits. And so that's been a big barrier to enrolling in clinical trials in general across the country. But there's something new that's starting out there, and you would think in the era of technology, why didn't I think of this sooner? But basically they're doing something called, there's a new company out there called the Hawthorne Effect. And basically what they've done is that the only time a patient has to come physically see us is at 30 days and at 1 year. After that, a trained, I think it's an NP or a PA or an RN, actually goes to the patient's house and actually does their 6-month, 18-month, and a yearly visit from year 2 all the way to year 5. They'll get vitals, symptom assessment, KCCQ, echoes will be done at the patient's house. And they don't have to come in for their visits at all. And this is kind of interesting. And this is the first time it's being done as part of a clinical trial. And we'll have to see. So for the patients that are coming from afar, there's a lot of pain up front in terms of all the number of trips they need to make. There's a little bit of pain at 30 days and 1 year, and after that, all the follow-up is actually in their comfort of their living room while they're watching the primaries on TV. I guess they're not primaries anymore. But in any case, I'll go through a couple of cases that kind of illustrate the type of patients that we're seeing, and then I'll kind of close, and this should be relatively quick. I know we're almost out of time here. So this is a patient who underwent a prior sternotomy and had mitral valve surgery a couple of years ago. So a young guy, 60 years old, and he got sent, actually it was one of the surgeons up north. He texted me, said, hey, I got this guy with a lot of TR. He came back into my office and he's having a lot of symptoms. Can you help me? I said, okay, sure. Why don't you send me his information? So he had a Carpentier-Edwards ring, a very big ring. He had a bunch of neocords placed, and he said, listen, he's got 1+ mitral regurgitation, and he's got all this tricuspid regurgitation. This is the right ventricle, this is the tricuspid valve, this is the right atrium. That big kind of mosaic pattern that you're seeing there, that's all tricuspid regurgitation. That's all blood going in the wrong direction. Okay? And we looked at, obviously he got a transthoracic echo, and when we looked at his his mitral valve, we noticed something funky. So I called him and I said, hey, listen, I'm a little concerned about this mitral valve. I think that, this may not be all just tricuspid regurgitation. I think there actually is something going on with the mitral valve itself. On the transthoracic echo, this is the left ventricle, the mitral valve, where he's had surgery, and the left atrium. And there's this very kind of prominent, what we call a pisa, and then there's a lot of color that kind of going in and out of plane in this particular view. And sure enough, when we get the transesophageal echo, one of the things that we see is that the entire medial aspect, or one side of the mitral valve, is still kind of degenerated, and there's a lot of regurgitation that's originating from there. And it's just so eccentric, you don't necessarily see it on the transesophageal or the transthoracic echo. This is the quote-unquote surgeon's view. When a surgeon opens up the left atrium and looks down at the mitral valve, this is usually what they see. So this is the mitral valve. These are kind of the core knots. There's kind of the knots that they use to secure it in device. And then all of a sudden you're seeing this thing kind of popping back, kind of the tongue that's sticking up at you, and that's actually the residual torn segment that's there. So hemodynamically, the patient had severe mitral regurgitation. Now this patient, we couldn't get up the leg. Normally when you do a mitral clip, this is what we decided to do with this patient, you can't actually go up the leg, or you go up the leg usually. Okay, in this particular patient, he had some weird anatomy, which is not too dissimilar from a patient like this, right? So prior IVC filter, and look at that, there's actually no blood flow going up the IVC. So how do you get a mitral clip system that's designed to go from down here into the heart to help treat the mitral valve and then ultimately talk about fixing the tricuspid valve in this guy? You can't necessarily do that. So guess what? We did the whole mitral clip from the neck. Probably one of the first ones in the world that we were able to successfully do, all from the patient's neck. Here's the patient's head. This is us at the head of the bed. The anesthesia guys and actually the anesthesia guys are here at the foot of the bed. The imaging guys are right behind us. The patient's feet are here, and we're actually staring at the screen, standing with the patient's head right there. And we're, again, coming in from the IJ, we're actually able to come in and basically totally put in one clip. And here's a patient with severe mitral regurgitation before. We clipped this side of the valve where the regurgitation was coming from before. Again, these are some hemodynamic parameters, and that little tongue that you were seeing before, you don't see it coming back out at you anymore. And well, what about that tricuspid valve? Did we go after that tricuspid valve at this point? And we didn't, because this was a tricuspid regurgitation before, and this was afterwards. So the TR got better. And so that was a point saying that, a lot of these patients that we see, they get screened heavily for left-sided disease. So it's very important to address the mitral valve disease first, very important to disease the aortic valve disease, uncontrolled hypertension first, and once those are addressed, if they still have this, then we will target their tricuspid valve at that time. So this is a case where all of that was done, where the mitral valve was addressed, the aortic valve was addressed, blood pressure was addressed. Here's what the transesophageal echo looks like. You see a lot of this mosaic color pattern, and that's indicative of the tricuspid regurgitation that we saw in this patient. Here's some additional views. It's called a deep esophageal view. And again, this is kind of a really important view for us, because what it does is it allows us to show basically you're staring at all aspects of the valve coming in and out of plane here. And this is just a very, very, very broad tricuspid regurgitation jet. For the imaging geeks in the room, we use something called X-plane, and you can kind of look at septal, anterior, posterior leaflets, and on the right side, it gives us the orthogonal projection. You can see the two leaflets. And then when you put color on them, you can see there's a fair bit of that mosaic pattern. Again, that all indicates regurgitation or leaking that's coming through. Okay, and so this is 3D. 3D is very helpful to determine, again, it looks nothing like the diagrams I showed you, but there's a septal leaflet, anterior leaflet, posterior leaflet, and this is 3D with color, and it shows you where the leaking is coming from. Transgastric views are also very helpful in determining where the source of the regurgitation is. So this is what the procedure looks like. We get the guide catheter, this outer catheter that sits in the right atrium right here, and then it kind of sits in the right atrium, and then you bring the clip in. And this is real time. This is what it looks like on echo. Those nice little diagrams that we have, it's far more challenging. And imaging is really our eyes for this procedure. The clip then comes in, similar to the mitral clip. The clip then comes in, we bring it down to the tricuspid valve. We can position it, orient it in multiple different locations and manners. We put color on to make sure we're kind of at the source of where the regurgitation is coming from. This is the clip opened above the valve. We kind of align it and position it. Now we've brought the clip below the valve. Once you're below the valve, you again open it, and you can see here, this is the clip arms that are open. There's one leaflet that's sitting on the arms. There's another leaflet that's sitting on the arms. And then you close it, and you kind of sandwich those two leaflets in together. And after you sandwich those two leaflets, you confirm that all the leaflets are in there. And remember, in this view, there was mitral regurgitation coming from this entire aspect right here, and now with that one clip, that bright thing that you're seeing is one clip, and there's no leaking coming from here. However, there's some still residual leaking coming from the other side. And again, if you look at where this clip is, there's no color. All that big torrential, mosaic pattern you're seeing is not there currently. So one clip is in, bring the second clip in, and kind of in a very similar manner, the clip is attached to the leaflets, and then when you assess by color, you don't see that giant color mosaic pattern anymore. Again, here you were seeing that giant color mosaic pattern, you kind of don't see that anymore. And this patient, makes it out to 6 months and feels a lot better as a result of the therapy. So, I'll close here. I'm a little bit over. I think if you talk about transcatheter therapies for the tricuspid valve, we've really come a very long way. We're learning a lot more. I'm learning a lot more with every case I do, with every patient that I see. It's complicated. The imaging, the anatomy, the pathophysiology. What is medical therapy? And that's also something that this trial is going to help understand what true medical therapy for the mitral valve really is. Is there a certain number of Lasix? Is there a certain dosage? Is it certain times a day? Is it a certain weight? Is it a certain right atrial pressure? We're not sure. And then we're learning a lot about transcatheter therapies. But at least from an edge-to-edge repair or a clip standpoint, based on our experience with the mitral valve, we know that it's safe. There's a very high implant success rate, and that has carried over to the tricuspid valve. TR reduction, I think, is going to be important if we're really going to have a meaningful impact on our patients' lives. It can't just be a one-grade TR reduction. It has to be more. It has to be a surgical-like result, right? Patients leave surgeons' operating rooms with 0 TR if they get a good annuloplasty. We need to kind of strive for the exact same thing for these patients who are too high risk for surgery. And then the question is, with these clip-based strategies, is it durable and does it matter? And that's what I think the pivotal trial will help us answer. So thank you for your time. Apologize for going a little over.
Thank you. Thank you so much, Gagan. That was amazing. I have to say, I think a lot about the tricuspid valve as a heart failure specialist. It was something we always talked about before we implanted VADs. It's something that came up a lot with our PH patients. And you're right, the medical therapy isn't as well defined for right-sided heart failure at all. There's really nothing in the guidelines to find that. So it's nice to know there's another tool in the box for our patients with refractory tricuspid valve regurgitation. I do have one question that came up in my mind, which is a very practical question. Because we're all used to MitraClip now, but there's a big difference between the mitral valve and the tricuspid valve, which is that we don't have to put things through the mitral valve on a regular basis clinically. But with the tricuspid valve, especially like in my field, we're putting biotomes, we're putting pacemaker leads, cardiomems, Abbott, and right heart caths. So what are the implications for passing things through a post-clipped tricuspid valve?
Do it very carefully. And so it can be done. People have done it. People have done biopsies. They put in additional leads afterwards. Micras have gone in after implantation. Have there been dislodgements? If it was very fresh or early, there have been. But I think we don't have a set, I don't know, Jeff, is there a set thing in the protocol? I want to say at least 6 months. I would wait at least 6 months. Have you come across anything set in the protocol as to when they can re-access the ventricle afterwards? Right, to go across the tricuspid valve after a clip? I haven't come across anything in the protocol. Yeah, I mean, we've done a right heart cath, definitely not the day after. We've done, I helped Dolly do a micra on one of those cases, but we waited at least 3 to 6 months, but that's also something we're learning. But again, under fluoro, very, very carefully. Yeah.
Are there any questions from the group? Dr. Scott.
Excellent talk. Thank you very much. I wanted to make one comment. It's interesting, when I got my cardiac surgery training years ago, there was nothing to do for tricuspids. Now, granted, that was about 20 years ago, but they would do De Vega annuloplasty, which is terrible. Then we do have a dedicated ring, 2 companies, that allow us to do tricuspid valve repairs, annuloplasty. In one of your anatomical slides, it was very interesting to show the conduction system. That's still one of the Achilles heels of a repair for a surgeon. The repair is actually very easy, much easier than a mitral valve. The issue, though, is that the conduction system is so close there, the triangle of Tenotodaro, and heart block is not infrequent. So that's sort of a comment I wanted to make. But otherwise, absolutely, if we do a mitral valve surgery, we can combine with this. So there's more of a comment that I wanted to make.
And that's why the rings are actually a partial rings.
That's correct. So we.
Fantastic.
Yeah.
The partial ring allows you to avoid suturing kind of right where the conduction system is.
Exactly. The question that I have actually has nothing to do with this. I wanted to know if you have any experience or what you do with tricuspid valve endocarditis. So, and it's a directed question. So we still do surgery for those, and unfortunately I've done not an insignificant number of tricuspid valve replacements, which is just not a good long term. Do you have any experience with the suction devices as a temporizing measure?
You know, what our surgeons have done, they've done a fair bit. I don't know, you know Doug, right? Doug Boyd. So Doug's done a lot of core matrix reconstructions, and so he's actually done. It ends up being almost a double surgery for some patients. And I think Kathy, you were there when you did a few of these. He's got a series of about 12 patients, and actually they're actually a pretty good outcome. He actually goes in, initially removes any sort of infected tissue altogether, and basically they're just left with torrential TR. Then he lets them go, and they actually tolerate that surprisingly well. I mean, it's not great long term, but then he actually brings them back after they're fully sterilized, they've been on antibiotics for a fair bit of time. Then he actually reconstructs, that's the best way I can describe it, reconstructs like almost a tricuspid valve type prosthesis out of core matrix. Then he kind of anchors it into the annulus, anchors it in down to the papillary muscles, and gives it some flex where there actually is some degree of coaptation, and it actually reduces their TR. But the key is to remove the infected material and then let them completely sterilize and make sure that they're going to stay off of whatever led them down that route anyway. And the downside is it's 2 operations. It's a pretty big deal. But fortunately, I think out of his series of 12 patients, they're younger patients, and their arteries were not blown out yet. I think that's why he was able to do it.
Okay, well, I'm going to close the floor to open questions, but we'll linger up here for a few more minutes. Thank you so much for coming.
Thank you.
Thank you.